Hello, everyone. My name is Nathan Tate. I'm one of the project managers for the ICD-10 program team. This morning, as part of the ICD-10 program team's documentation assessment effort, we were to provide a series of specialty-specific presentations that are more focused on your particular areas of interest. So today's session is focused on neuro, ortho, and trauma surgery. And we have other presentations that focus on different surgical specialties. We actually have these posted out on the ICD-10 website, so you can view your schedule permit. I will turn it over now to Alan Frady, our presenter, for an introduction. And throughout the presentation, I will be sending out notifications through the WebEx chat with links to the ICD-10 website where you can find some of those other presentations. So I will turn it over to you.
My name is Alan Frady, and a little bit about myself. I'm a registered nurse. I work primarily in ICU, a step down, open heart recovery, and then I was also a case manager for a number of years and a coding auditor, contractor, as well as a coding director. And for about the last 5 years, I've been doing CD. And about the last 2 years, I've been focusing on ICD-10 and doing a lot of training in that area. So, as Nathan said, these in-services here are primarily broken out to specialty areas. Today is a surgical session. For the first half an hour or so, we'll be talking about some general surgical concepts, and then we will be looking at some specific trauma, ortho-type procedures, as well as some of the documentation and a few of the issues and opportunities in ICD-10. So with that said, we'll get right into it. So we're talking about complications, general surgery, complications, when to report them and when not to, and when to report them as a direct result of the surgery and when not to. We talk about anemia, debridement a little bit, pneumonia a little bit, renal. They're not specific to ortho, neuro, and trauma, but all surgical patients get these diagnoses on a very common basis. And the reason why we selected these to all the sessions is because they showed up in the top 21 opportunities for your surgical population. And then we'll get into some things that are specific. We have about 10 slides at the end. All right, so let's take a step and talk about why this is important. Just about increasing revenue for a hospital. There are a lot of initiatives going on right now that have to do with quality, profiling, outcomes, and based purchasing incentives and such as that. So pretty much any time a CDS brings you a query, whether they're asking for something that doesn't seem important or maybe important, depending on your particular mood that day, realize that just about anything that a CDI would query you for is going to impact your risk adjustment and your population-based incentive reimbursement as well for your personal practice, as well as your quality profiling for things like the National Quality Foundation. A lot of these things can be patient safety indicators. They can affect morbidity, mortality, and risk adjustment. So really they're there to help you. And one of the things that I sometimes say is their entire job is to make it look like you're the best physician you can be, dealing with the most difficult patients good to have with the best possible outcomes in those patients. And a lot is about risk adjustment. We'll talk more about that as we move forward. Surgical procedures. For any diagnostic procedure or surgical procedure, the provider must document the reason the procedure is being performed, the specific description of the actual procedure, as well as supporting procedures. And we also need to know the exact anatomical locations and the sequence of events. The things should be in your operative note. We would need the outcomes and any intraoperative conditions that developed that would be considered to be reportable as well. Okay, remember that we use the words complications and complex kind of interchangeably, and we shouldn't. Something that is more complex is not necessarily complicated and or a direct result of the procedure, and when some of these terms don't always imply a direct medical misadventure. Now, some do, and so we need to kind of distinguish the ones that don't and the ones that do. Remember that certain things, and we'll talk about acute blood loss anemia today, may very well be expected occurrences out after surgery, and they don't imply any medical misadventure whatsoever. Any addition that increases resource consumption, however, should be reported. So if we've got to do extra labs, if we've got to do an evaluation, keep them in the hospital an extra day, or provide extra treatment, that should be reportable. So what that we've started doing and changing our sort of philosophy in querying and coding is not just trying to assign everything with that cause and effect relationship that would imply a surgical issue or misadventure, and just, trying to up the severity of case-by-case basis, which is a little short-sighted when you're looking at the value-based purchasing, the patient safety indicators, the quality, and the mortality statistics. So that's kind of how we started teaching this, I guess, in the last year or two. First and most, does a cause and effect relationship exist? The procedure or the medical device must have a direct cause and effect relationship to the negative outcome, and if that cause and effect relationship is unknown, then the physician could receive a query in that example. And if you don't necessarily know if it caused the event or if it was a direct cause and effect relationship, just answer as truthfully as possible. The goal here is to capture the truth, the clinical truth, and really don't know, we don't think it is, and we probably shouldn't call it that unless we know for sure. The next thing on here, what I've labeled as the Smith test, is a foreseen circumstance is never a complication, even if it does require additional resources. So, for example, the example that I always give is if you're going in and debulking a tumor, say the patient has a tumor on the spine, or they've had some kind of they've got pressure there, and we get back there, you see that it crosses a vascular bed and there's going to be significant bleeding. You may have to call vascular in, but you see that, you make the conscious choice to go ahead and treat it, knowing that you're going to have additional resources and that it's going to be increased bleeding. That's not a complication, that's just a more complex case. We shouldn't use the threshold of, well, we had to call in a surgeon or where we had to give blood to call it a complication. It was a foreseen circumstance. It was planned. Maybe didn't know a day in advance, but as soon as we opened them up, we knew what we were dealing with. Another bullet down here is the standards of care, is the outcome and event that can be reasonably expected to occur on a regular basis. Does it occur greater than 50% or greater than 60 or 70% of the time? If so, that's not considered a complication. That is part of the standard of care for that particular treatment, and we shouldn't be labeling those as such. As an unforeseen outcome, again, if we have an unforeseen outcome but no harm came to the patient, well, that's probably not a complication either. It was just noteworthy. So it did harm to the patient. What I mean by that is if the unforeseen outcome caused us to have to give additional treatment or keep the patient extra days or do additional services. So it's got a lot of standards here. It's got to be an unforeseen circumstance that does harm the patient and falls outside of the standard of care. In those cases, we would report it as a complication. I'm not saying it doesn't happen. I'm just saying that in the past, I think coding and CDI have been too aggressive with looking at that and have sort of alienated our relationship with surgeons. In particular, we need to align our goals so that we are all on the same page and working towards reporting these when appropriate, but with the same set of standards and indicators, and that's sort of what the goal here is. Some examples from coding clinic would be a foreign body recovered during surgery, even if the patient had to have a reopening of a laparotomy site. We used to do it that way. If you had closed the incision and had to reopen it, that was automatically considered a foreign body. But relax those standards. It's not considered a foreign body until they leave the OR suite and go into PACU. Then you see that they have to go back. Well, then it's going to be reported as a foreign body. There's no way around it at that point. Affected pneumothorax because you crossed into the diaphragm, or you had 5 or 10% post pulling a chest tube. Those shouldn't be reported as post-op pneumothoraxes. That's the standard of care. You're always going to have some pneumothorax whenever you invade the thoracic cavity like that. And if you have a pneumothorax that's greater than, say, 15%, with additional chest x-rays, really double down pulmonary toilet, maybe consider whether or not we're going to have to put a chest tube back in or tap it, do extra chest x-rays. That should be reportable, but we generally don't worry about 10% or less because it's common to see a 5, 6, 7, 8% pneumothorax after the chest tube comes out. So be careful about writing that as post, thorax. Just write it day 3, patient has a small pneumo. Then we can still capture the pneumo, but without the cause and effect relationship. It is a cause and effect relationship that dings you in your quality. So if it was a pneumo due to the procedure, then you're going to get an additional code for a respiratory surgery complication. That's the one that dings you, and that's the one you don't want. Diagnosis is okay. The cause and effect relationship, only report when it's absolutely warranted. Also remember, on medical devices, same set of rules, but if they were present on admission, we don't get dinged in the same way. We only get dinged for things that are hospital acquired. So if you suspect that long-term indwelling Foley catheter that they've had is probably what caused the UTI, it's okay if it's present on admission. It's when we give it to them after 2 weeks in the hospital that it really starts to something we have to look at in terms of our quality. So use your best judgment in those cases. The third example is acute blood loss anemia. You've got a fracture patient, expected blood pooling into a joint. Hey, that's expected. There's no medical misadventure there. There's going to be a lot of blood loss when you do repair. So you can just document that as expected acute blood loss anemia. You get the acute blood loss anemia, you get your risk adjustment. Again, these diagnoses help you with your length of stay, your repeat admissions, and your cost of care. As long as you don't say it was operative hemorrhage or intraoperative hemorrhage, then you're okay. That's the word that the intraoperative hemorrhage is what's going to ding you, and that's when you only want to report it when there's absolutely no around it because it was just a catastrophic procedure. Then you report that. Let's look at some. These are particular to the renal system, but these are in no particular order. You've got complications of stoma and urinary tract, but look at the bottom one, intraoperative hemorrhage and hematoma. It used to be we just had one code for this, intraoperative hemorrhage and hematoma, but now we would have intraoperative hemorrhage and hematoma for musculoskeletal system, for the thoracic system, for the vascular system. It's all by body systems. That's good news, bad news. That partially explains why we have so many new codes. But again, the care that we've given and the diagnoses that we deal with here didn't change. There's just more ways to report it. And your accidental puncture or laceration, again, that can be vascular, that can be thoracic. This particular happens to be genitourinary. But if you have that's the code, that's the terminology that's going to ding us in our quality a little bit. It could be it was unavoidable still, but if we have to report it, that's where we've got an issue. The coders look at it, again, if it was an unforeseen circumstance and then you have to go and do an extensive repair, they see that as something that probably should be reportable, and it should if it was an unforeseen circumstance and then you have to provide all additional resources to deal with it. Okay, so documentation considerations. The visit should clearly link between remitting symptoms and the cause. In this example, they're using renal, but any sort of what we're looking at here is present on admission. So, for example, if you have any sort of device that the patient had that you're thinking have caused the admission, we need that linked back so it can be present on admission. It does change the coding. So, for example, if you have a post-operative that has become infected, and what we see is the patient was admitted for sepsis, and then 3 or 4 days later, buried in the progress note, it says, oh, yeah, the wound was infected, might have been sourced. But that's all it says. That's a really gray area. It's hard for the coder to say, oh, wait a minute, was this an infected wound? Because that's going to change your DRG. It's going to change your risk adjustment. It's going to change your quality, everything. So getting that linked back, and so that becomes a primary diagnosis, and the sepsis becomes secondary, for example, would be very important. About acute loss anemia, again, may be expected. Another example of a diagnosis that but doesn't imply any surgical misadventure that we talk about a lot is the post-laminectomy syndrome. Again, there was nothing that happened. The procedure went great. It's something that happens sometimes. Because it has that term post-laminectomy for the coders, it doesn't mean it was due to the procedure. It just means it occurred after the procedure. And that's where we get into a lot of trouble. If you have a major laparotomy type of procedure and you have post-op illness to the coder, that means that it was ileus due to procedure, and that implies some kind of medical misadventure. However, if the patient didn't have any bowel manipulation, for example, and you use that same term, that's very problematic. So what we would prefer, if you don't think that cause and effect relationship should be established, is to say day 3, patient now has illness. The illness is due to their medication or some other condition. Maybe they have abdominal adhesions completely unrelated to maybe they fractured leg, and that the surgery was for, and that's unrelated. So you don't give that cause and effect relationship. It's just ileus, day 3, patient now has ileus. And then you get around having those complication codes assigned. Procedures often involve significant blood loss. If we're dealing with trauma, we're going to always be dealing with significant blood loss. Again, there's nothing wrong whatsoever reporting acute blood loss anemia. You'd be amazed at how much severity that adds for us. It is a good indicator that blood loss is more than expected. It's not necessarily always required to report acute blood loss anemia, but if they did get a transfusion, it's a pretty good indicator that we may be able to report it. Other thoracic procedures such as a CABG or someone who had a vascular, maybe a traumatic amputation, that's going to be an expected finding for sure, and you're not necessarily just going to say, "Oh, look, I found a transfusion. We can report this." The doctor needs to say, in this case, it was acute blood loss anemia. We look at a 2 to 3 point drop, and we generally don't our CDS to go and query for this unless they drop below about a 10. So if they have a 3-point drop, but they're still hanging on at 11 or 12, we're not going to push that. But on the other hand, if they're severely, if they're an elderly patient or a very young child, if they are compromised in other ways, and we could look at that drop as being more significant. We've also started teaching to look for the causes of hemodilution and consider that patient got a lot of fluid and just had a couple of points. And that's not worth querying over. If they had a lot of fluid and dropped by 4 or 5 points, you still may want to query for that. So what we're trying to do here is eliminate some queries, make our queries more clinically valid, and it's something we're going to have to do because of ICD-10. We're probably going to have some increase in queries that just is the nature of the beast there. Training surgery, DVTs, infections, heart attack, medication reactions, hemorrhage, acute respiratory failure, foreign body, post-op wound issues. These are all things that are going to give us a lot of risk adjustment for these patients in the surgical population, trauma population, neurovascular, and so on and so forth. Don't forget the DVTs and PEs. Again, if it happens while we're in the hospital, that's a hospital-acquired condition. That's a patient safety indicator. We really need the PA status nailed down if it appears that they had that on admission, so we can get that it was present on admission. And the same thing for a lot of these things. If the hemorrhage occurred in the outpatient setting, we want that to be established POA, because it was a trauma or something, respiratory failure, and so on and so forth. So they query for acute blood loss anemia. The patient had 1 liter loss of fluid. We gave them 2 liters. Their hemoglobin dropped from 13 to 8.9, and this was an expected blood loss. This was a thoracic procedure, in this particular example, aneurysm of the heart. But the terms that didn't work were blood loss, the transfusion, expected blood loss, and just had acute blood loss anemia impacted us by over 2 days in our length of stay and a large amount of risk adjustment. So what they're saying here is it's expensive. If you got that, it's going to mean that they're going to be in the hospital for a couple extra days. The transfusions aren't cheap. The blood work's not cheap. They could have gotten hypotensive and maybe moved up to an additional level of care. That's very expensive. So it's a lot from something that you wouldn't think of as being at the top of your list and what you're dealing with on a trauma or surgical patient necessarily. Something that sort of routine for that patient population, but it's amazing how much risk adjustment some of these diagnoses give us. Surgical debridement, we need the term excision, which is the removal or cutting away of devitalized tissue. The code do require the word excision to be present. If you do an incision, even though the op note may be exactly the same, they may not pick it up. The sharp debridement also does not work very well. What we need is the documentation showing the exact method or technique, excision trimming, the instruments used, whether it's scissors, scalpel, locating the appearance of the wound, the depth of the wound, as well as what was taken out. Did we go down to skin, fascia, muscle, or bone? So if you got a traumatic, maybe it was an MVA with a motorcycle, and there was road rash. There was also some deep wounds with a lot of foreign material in there. We need to know. Say, well, I debrided to the muscle. Okay. Well, does it mean you debrided down to and including the muscle, or does that mean that you debrided down to and not including the muscle? Be aware how these terms can be interpreted in different ways. We need to see that you didn't just scrub it out, irrigate it, use some kind of a jet on it. We need to actually see that you use the scalpel and you remove tissue down to viable, healthy tissue. You'd be amazed, again, at the amount of risk adjustment, length of stay, and resources that are added to a case by something like an excisional debridement. In this case, it's not a typical query. We're not asking you if you did or you didn't do it. What we're going to just do is probably query you for the instrument used, depth, type of tissue, and location, and from there we'll figure out whether we consider it to be excisional or non-debridement according to our definitions. The terms that didn't work were debrided, sharp debridement, or wound debrided. And look at the length of stay, almost two additional days, because you had to go and do that debridement procedure, and the risk adjustment went up quite a bit as well. So, and it's in the same way that I was talking about the blood loss anemia, don't forget that you have a risk adjustment from something like this. A lot of these are done by plastics, or the trauma surgeon, whoever just comes by and does it in the room. The parts note just may say debrided and nothing else. It's not going to work. We're going to have lost these additional days and this additional risk adjustment without this additional information. Okay. Patients, a lot of times you are going to deal with things like pneumonia and respiratory failure. These are the criteria that we are now teaching the CDS, including the PF ratio, because we recognize we don't always get good gases. Just going by pulse oximetry and how much oxygen alone can be strengthened a lot by just actually adding in the PF ratio as part of that. And a lot of times we don't know their baseline. Is not a requirement, but again, we do look at a pulse ox less than 90%, the typical respiratory rate greater than 26, speaking in one-word sentences, hypoperfusion, I don't know if I missed O2 greater than 4 or 5 liters, and any kind of situation where they are having to be put on BiPAP. All of those conditions would probably raise a red flag for the CS. If you were just documenting respiratory insufficiency or respiratory distress, that's not going to work. Those are just going to be looked at signs and symptoms, and you're going to get no additional severity added to your record. This is the first point here. Some additional things that we can capture in ICD-10 would be acute versus chronic. We've always kind of had that, but it's acute versus chronic and acute on chronic. There is now a condition for post-op chronic respiratory failure, which is interesting. We never had that before. I think that's something we'll probably use in the trauma population was a good example where he ended up on the vent long term. It was unexpected. So at first it was just post-op respiratory failure, but then after week 3, it's now chronic post-op respiratory failure. So you've got both conditions there. If you were getting the patient in as a transfer from another facility and they were still in the vent after having been in another facility, that's probably going to be one of your diagnoses, and that would be a very highly weighted, very sick patient that you're going to get credit for. You also can do hypercapnic versus hypoxic, or both, and whether or not the respiratory failure was present on admission. So look at some of these codes. And I haven't actually called this one out. We looked at this slide before in some of the other presentations. But you can see on the left you've got your pulmonary insufficiency following surgery. And then over on the right you've got your acute pulmonary insufficiency following surgery, acute pulmonary insufficiency following non-thoracic. So the top one is thoracic, second one's non-thoracic. And then you've got just surgery, but look at that closely. That's your chronic. That's your patient who never really got weaned for more than a week or two. I don't have the exact time frame, but I assume it would probably be more than a week before we'd start looking at that diagnosis. And so if they were long-term, we would use that. And then we have post-procedural, so maybe they had a procedure done that wasn't a full-on OR procedure, such as debridement, a chest tube, a spinal tap, some kind of emergency procedure done in the ER. Instead of using the thoracic or non-thoracic or surgery, we would use post-procedural respiratory failure and have our acute respiratory distress syndrome. Remember, not everybody who is in failure or can't be weaned off the vent after surgery is in ARDS. Generally reserved ARDS for our trauma patients, or our shock lung patients, or patients who have barotrauma from the vent, some kind of trauma. The actual intrapulmonary changes would be what we would reserve ARDS for. Everyone else who just has poor gas exchange, or maybe they had a chronic pulmonary condition or a lot of fluid balance issues, we would just use the standard respiratory failure. And by get confused by the term insufficiency, we really try to avoid encouraging physicians to document insufficiency, because in the absence of a surgery or trauma, insufficiency doesn't give us any severity. So if you'll just go ahead and call it acute respiratory failure following thoracic or non-thoracic, just use the word failure instead of insufficiency. It would make it a lot easier for everyone. If you're going to say, in general, as a rule of thumb, if you're going to call it insufficiency or distress, please put the word acute in front of it. That captures that middle level of severity. Failure generally captures the highest level of severity. That's a general rule. Anything for acute on chronic, generally acute captures that highest level of severity, whereas chronic captures that middle level of severity. So this is a patient who has, I believe they had CHF, if I'm not mistaken. Look at the criteria. In the ED, the PF ratio was 187, respiratory rate 25, one-word sentences, a low OSAT on 6, so we put them on BiPAP. They had a history of COPD, and the H&P even said respiratory failure decompensating. We still didn't get it on this record because it was only in the H&P. You can have a patient, especially again with your trauma population, have respiratory failure that quickly resolves. It responds to treatment very well in some cases, and so it falls off the record very quickly, either in ED or in the H&P, the first day of progress notes. The code, RAC, the commercial insurances are all going to see that as a differential diagnosis that was never confirmed, and they remove it from the chart. We're not going to capture, and we're talking about a lot of risk adjustment, severity, and cost here. All that's going to be removed. You can write respiratory failure in ED or respiratory failure through day 1, now resolved. That tells us that it wasn't ruled out. It wasn't a differential. They did have it. It just resolved quicker, and now we can report it. So if we saw that again, maybe in the final progress note or in the discharge summary somewhere, would also help us. Even if you're not the physician who treated that initially, you can still report it. This is different from your E&M guidelines where you can only report E&M level for the time that you spent. For the hospital reporting, we're required to report all conditions that were, monitored, diagnosed, or treated during stay, not just the ones that physician X saw or the ones that physician A, but all, and we're required to report them all. We're not given the option of picking and choosing. So it would really help the hospital out a lot if you would write that. You could even write, failure, documented by Physician Smith, now resolved day 2, problems that I'm dealing with are, and you could write it that way. You're simply giving the medical course of the record. Your point that condition wasn't ruled out or they didn't decide that they didn't get it. It's just that another physician treated it and it was resolved before you got to it. We really need that. It would help us out a lot. Terms that didn't work, by the way, are the respiratory decompensation, respiratory insufficiency. Again, you can see a huge jump in the length of stay and in the risk adjustment by having respiratory failure here. Respiratory failure, I mentioned hypoxic and hypercapnic. The defaults have changed. It's a little bit more for the coders, but it used to be if you just said respiratory failure, it automatically defaulted to acute. Now it defaults to unspecified, but it still gives us that highest level of severity, so that's actually okay if you just document respiratory failure, even in ICD-10. And the new surgery respiratory failure codes, which you can see here. Pneumonia. Again, you have a traumatic issue with the lungs or an issue with a patient who has a lot of fluid balance disorders, such as a shock patient. You can deal with pneumonia a lot. This is just meant to show you some specificity that we can capture in the type of pneumonia. Don't forget, ventilator-associated pneumonia needs to be specifically called out. You can see, again, there's a lot of specificity in some of these. Some of you probably wouldn't see that often. Top one, maybe the pneumonitis due to inhalation of other solids and liquids, is essentially an aspiration pneumonia type of scenario. If it was a chemical or they were submerged in water, something like that, it would be good if we could get all that, so we could get because there's going to be some additional codes that go with that. Okay, then we've got our influenzas. You can see, again, just some of these have to do with pneumonia as well. All right, jumping into renal failure. Again, this is very important, especially in our population. If you have a patient with a hypoperfusion event, this is how we teach it, hypoperfusion event, and then suddenly have a spike in renal labs, BUN creatinine, and the physician's document is AKI, but you see that they aren't responding to IV fluid resuscitation for a couple of days. That's telling us that it's probably not pre-renal, right? It's probably not just dehydration is probably an intrarenal. Oh, and by the way, we did have that hypoperfusion event just prior to the AKI setting in. We'll probably at that point go and look and see if we have an acute tubular necrosis. The way this works is if you just have acute renal failure, that AKI, that pre-renal diagnosis, that's a moderately ill patient. But if intrarenal pathology, acute tubular necrosis, that's a very ill patient. It's a severely ill patient. If there's azotemia or insufficiency, no additional severity. That's just your base patient on whatever their principal diagnosis was, and you get no additional credit for the renal function issues. Some of the chronicity here, chronic CKD 4 and 5 give you the moderately ill. End-stage renal disease also gives you the severely ill patient. It's noteworthy that about 30% of all hospital treated in-house KI is actually ATN according to KDGO in 2012, which is the most recent, the best information we have. We don't see it reported at that rate. We see it reported between 5 and 10% tops. I think we could, it's realistic to always go for that 30% because in academia they are probably doing more renal biologies and they were working up the patients and expending a lot more resources to get to that diagnosis. But I think we can report it more than 5 to 10%. There's opportunity for improvement. And while things like interstitial nephritis and glomerulosclerosis have to have a renal biopsy, ATN can be clinically diagnosed based on treatment. If cells in the urine electrolytes would be good to have. You can look at it clinically without the renal biopsy, and in most cases, look at the cause and effect relationships, and you can diagnose it. So it's something that we do push quite heavily. Okay, encephalopathy, metabolic, for example, but it's not always just metabolic, but it can be caused from things such as hemorrhage, stroke, brain mets, tumors, cerebral ischemia, poisoning, and infections. It's a common finding in 12 to 33% of patients who have multiple organ failure. A lot of people will shy away from encephalopathy because they aren't quite sure when it is reportable, when it shouldn't be reported. It's not reserved just for the long-term chronic degenerative brain disorder. It can be for short-term metabolic problems, obviously, which can be corrected by reversing those metabolic hemorrhagic type of issues. So this is something that we do look at heavily in terms of our querying. No, we shouldn't be using it if we have a severe patient who's post-ictal or a patient who's hypoglycemic. We shouldn't be using it for those very, very transient types of confusions. We should use it for a patient who's very hyperglycemic. We have diabetic coma for that. If we have a patient who has failure and elevated ammonia levels, and I have a slide for that coming up, we can't just report hepatic encephalopathy for confusion anymore. In ICD-10, they have to be in a full-blown coma before hepatic encephalopathy is reportable. So we probably have to report metabolic encephalopathy due to elevated ammonia instead. So it's a little bit of a change there. We really do need to capture that. The encephalopathy does give us that highest level of severity. Some examples. You'll see the toxic. Be aware of the toxic toxic encephalopathy is reserved for in the coding world for cases where you have a chemical or a drug type of exposure. Toxicity is looked at as a foreign substance, not a naturally occurring metabolite that can't be processed. So sometimes physicians will say toxic metabolic encephalopathy. It would be best if you just called that metabolic encephalopathy if it's a naturally occurring substance that the body can't excrete or metabolize, and save the toxic encephalopathy for the patient who has an exposure to a chemical or an overdose or poisoning. Hypertensive encephalopathy is just a moderately ill patient, as is alcoholic Wernicke's and anoxic. I believe anoxic should be the severely ill patient, but in some cases we'll report that for a patient who is mildly confused because they're in respiratory distress and they're slightly anoxic. In that case, yeah, I can see it being just a moderately ill patient because it's reversible. We're going to treat the hypoxia, and then their mental status is going to clear. That's probably okay in that example. When you're using the term delirium to describe the observable manifestations, RAC is going to see that as inconsistent. So they'll say, well, he wrote delirium on page 3, and another physician wrote encephalopathy on page 7. We think it's really encephalopathy. This is a vague diagnosis. We're going to take it off. lost a lot of that risk adjustment. ICD-9 and ICD-10 reserve the term delirium. Basically, they look at it as a psychiatric diagnosis. It either goes to a sign and symptom, or it falls between dementia and drug-induced mental status changes, which would not be an appropriate way to classify someone who has an underlying systemic medical problem causing brain malfunction. So I think we could use delirium, for example, if they have a drug-induced situation. I usually reserve that for someone who has a medication that is psychoactive, benzodiazepine or sleeping pill or a narcotic, and they can't come out of that post-anesthesia. I think is probably a good way to do drug-induced delirium. That gives us our moderate level of severity, but if they are on a medicine, for example, they double-dosed on their diuretics and got severely hyponatremic or hypernatremic, that's metabolic encephalopathy with an indirect connection to the medicine. So that's sort of how I've sort of handled this. I know it's extremely confusing. Somebody has to look at this. And so consistency is key. If you're going to go with delirium, stick with delirium. If you're going to go with encephalopathy, stick with encephalopathy. In ICD-10, we have a new code. Some of these scenarios give us a little bit more clarification. You can see we have subacute infective psychosis. That could be our 70-year-old lady with a UTI who has no other reason to explain her confusion except that. This is a code that gives us our moderate level of severity. I'm trying not to encourage people to query for encephalopathy for localized infections, only for systemic conditions. We also use this for sundowning and delirium superimposed on dementia. But if you have a medical reason, so they came in, they had hemorrhage, they had rhabdomyolysis, the sodium was all out of whack, that's probably not just delirium superimposed on dementia. That's an underlying metabolic encephalopathy. It's not a psychiatric problem. So again, this is the review here on the hepatic encephalopathy, which won't be codable unless they're in a full-blown coma. All right, let's see where we are on time. Okay, so procedures. In ICD-10, procedures are going to be a major challenge. Typically, CDI does not query very much. They don't spend a lot of time reading op notes. That's the purview of the coder. So with things like principal diagnosis and whether they have a complication or just a complication, we look at things like hospital-acquired conditions, third-degree admission rules, patient safety indicators. We look and see if we have an alternative principal diagnosis because of present admission guidelines, and I mentioned that with the sepsis, the respiratory failure, whether those were POA or not. But we don't really look at procedures, and procedures is something that is probably, it's said to be the largest growth opportunity under ICD-10 for CDI is to start looking at procedures. A lot of it would be to look at procedures just to help the coders figure out how to code it and not necessarily to query the physician. There is a lot of clinical expertise and anatomical expertise, things that the CDI may have that the coder could struggle with, and I think a partnership could be in order there in order to help with some of these procedures without bothering the procedure, without bothering the physician. An example here has root operations and open heart procedures, having adhesions. About 100% of them have adhesions, requires a lysis of adhesions. Typically, some incidental injuries are common. You've got lysis or adhesions, you have to look up the root word release. And again, that's something that may have come out of that partnership between CDI and the physician may say, but the pericardium wasn't physically constrained. So we figured out the root operation, but we had a problem with our anatomical sites. In this case, we would need to know if it was the right or the left atrium, the right or the left ventricle, or the pericardium. There's no code in ICD-10 for heart otherwise specified. So now this record is held, and the cardiovascular surgeon, in this case, is definitely getting a query. This is an issue. This is hopefully the exception to the rule, but this is something that we can maybe fix with operative templates and quick tips as we move forward on some of the vascular procedures, for example. Nowhere in ICD-10 are the terms ectomy, ostomy, otomy, ablation. Those terms are gone. They're nowhere in the 72,000 codes. You need to know the actions, the end of the procedure, and the reason why you need to know the intent is because we need to know if it was diagnostic or therapeutic in some cases, and the exact technique and sequence of events. We're not to be querying the physicians on root operations. We're supposed to be able to look at the technique and sequence and figure out the root operation, and I think 90-95% of the time we will be able to. Here are the characters that a coder is challenged with in ICD-10 section and body system will be pretty easy to figure out. How root operation we just looked at, knowing to look up the word release, that could be a challenge. The part we also saw, knowing the exact part of the art, things can be very challenging. And then with the approach, that can be just confusing. I think that's another area that CDI could work with the coders. And then devices. What are the rules on devices? What counts as a device that's left in or not left in? Look at these root operations. So you'll see that controls reserved for post-operative bleeding, I think will be okay there. Creation is reserved in ICD-10 only for gender reassignment procedures. So you cannot create an AV graft according to ICD-10 that would be a supplant or supplement, which would include patches, stents, and aneurysms. So what we're having to do here is learn a new language. And some of it seems kind of ridiculous. We are reassigning the meaning to words that are different than how we used to use them in order to arrive at a comfort level of doing this. And there's going to be a learning curve, no doubt. Removal, for example, is reserved for device only, so you remove a tumor. No, you didn't. You actually excised it or you resected it, but if you removed it, that would have to be a medical device. You can remove a pacemaker. And it's up to the coder in most cases to try and figure this out, but I just want you to understand what kind of challenge the coder is up against. Fusion makes more sense, joining together and immobilizing. I don't think we'll have any problem with that. I've already seen some confusion in audits that I've done between occlusion and restriction. Occlusion is completely closing it, and restriction is just decreasing the inner size of the lumen, and I see that used almost interchangeably by coders. That's going to be a problem. Fragmentation, breaking up, something would be like your extracorporeal shockwave lithotripsy. And change is also for a device or prosthetic, like a hip change. Change would be the root operation in that case. So there's a lot of challenges here. And then when we look at, in this example, this patient had a left saphenous vein removed, and could tell maybe the anatomy wasn't good or the op note wasn't good. Couldn't tell if it was the lesser or greater saphenous vein. And the record had to be queried to the surgeon to find out, was it the greater or lesser saphenous vein? That goes back to that anatomical site I talked about in that body part. Very specific in your anatomy and your operative notes going forward. Resection is reserved for when you take out entire organs. So if you have a total nephrectomy, that's a resection. If you have a partial nephrectomy, that's an excision. And I think we'll be okay on that as long as you document very well. The joke was, what if you have a cholecystectomy? Don't say anything else. Is the coder going to assume it was resection? Generally, coders don't like to assume. But when's the last time you saw a partial gallbladder taken out? It probably is resection. So I think that there's going to be some discussion around that, hopefully without too much pain. With the bar, they're told to assign the closest match, and the question is, are they going to be comfortable with the closest match? There is no closest match for the saphenous vein, for example. We'll need to know the specific parts of the bone, the specific depth of the receiver, and the specific fascial bed of the organ. Approach, again, confusing in some cases. You would think that a tonsillectomy would be a procedure that was performed through but it actually goes to external simply because they can reach it without any instrumentation or type of guidance, so it goes to an external approach. It's not open, but it's external, so it's kind of interesting. If they have a small procedure, that's percutaneous, and if they have a small procedure with an instrumentation, that's percutaneous endoscopic. Again, they figure all that out, but they just need the detail in the op note in order to apply these definitions. Worst case scenario here, in radiology, this patient had an angioplasty of other non-coronary vessel. It was one code in ICD-9. It's 1,170 codes roughly in ICD-10, depending on the exact location of the artery and the exact type of device and what the approach was. And it's mind-boggling that we can get almost 1,200 codes out of this one procedure, but we can. So that's that specificity that you've been hearing for years. Devices. We import devices when they're permanently and intentionally left in. So that would be a graft, an implant, a prosthetic, an electrical appliance. And in some cases, we do know if it's autologous or synthetic or non-autologous before we can finish coding it. We wouldn't code things like temporary veins, sutures, things like that, devices that were used during the surgery, but were either intrinsic to the procedure or not intentionally left in. That's going away, so we can't do a Whipple, Nissan fundoplication, Bill Roth 1-2. All that's going away. We'd have to know Nissan fundoplication was restriction of the proportion of the stomach. We'd have to be able to break it down that way in order to code it. Whipple is going to be very complicated because there's so much diversity in how that's reported. So that's another challenge. What pieces of the procedure are inherent and pretty much routine is another area that I think CDI are just going to have to work directly with code to make sure they get it right. For example, with the cabbages, they've known for a while you don't necessarily have to go and report the hemiplegia that gets put in, hypothermia, all of those additional steps. The only thing that they do is the cabbage, how many grafts, and whether or not heart-lung bypass machine was used. Everything else, temporary pacing wires, chest tubes, is all considered intrinsic to the procedure. Well, now they have to do that same thought exercise for every procedure that they do in order to make sure that they separately report, can be separately reported, and don't unbundle inappropriately. And what's the intent, interpretation, and specificity? If there was a creation of a valve in CT surgery, we probably need to use the term supplement instead. If the surgeon's any rod placed in the femur is automatically an ORF, although it may not be classified as such in coding because they did the reduction, they reduced the fracture prior to making an incision. Coding considers that as a closed reduction, internal fixation. So, again, there's just a mismatch between the clinical terminology and the terms that we commonly use in surgeries. All right. Spine procedures. Spine diagnoses and spine procedures, we need to know, again, the spinal region, the vertebral level, the specific disorder, such as sciatica, lumbago, trauma, fracture, whether or not there was a lesion of the spinal cord is going to be huge. If there's an underlying disease or if there's underlying hemorrhage or additional nerve vascular damage, if post-procedural surgical complications, and what episode of care. Is this the initial episode of care, or are they coming back in for a procedure to follow up previous for a trauma maybe a month or two ago? So you see that there's, again, a lot to this, but it's really the challenge is getting the ancillary injuries. If you have a vascular bed that's cut or a nerve that's not part of the spine somewhere that's damaged, additional procedures and injuries need to be all very clearly spelled out, not necessarily just that number one problem that you're focusing on. Spinectomy is another common issue. We need to know if it was done for a neurological issue or if it was done for a musculoskeletal problem. So those kind of overlap. The musculoskeletal problem is probably causing the neurological, but it can change the DRG and the severity depending on what that primary reason for admission is. It falls in multiple categories. Something that we need for a laminectomy would be the approach. Is it anterior, posterior, lateral? The fusion. Again, anterior, posterior, or 360. What type of bone graft was used? What devices were used? Was there an incision of disc material? Location and the number of vertebrae fused. If we have all those pieces, and a lot of times that will all be in an op note, but what's frustrating is sometimes there'll be one piece missing, and it holds up the bill. For example, was it an autologous graft, or where did they take the bone graft from? That might be missing. Unions, failure of hardware, device complications. You can see this impacts the DRG and the categorization in many cases. It goes to different places depending on what the underlying cause was and whether or not there was a cause and effect relationship. All right, let's talk about the Glasgow-Coma scale. This is something that is going to be a huge opportunity in ICD-10 to report. It's going to have a major impact on your risk adjustment and expected length of stay. And we need to know the individual scores. And we also need to know where it was done at. So in the example here, it's done arrival to the ED, and you can see we've got best eye response spontaneous, and got that into the second code. Coma scale opens eyes spontaneously at arrival to the emergency department. Don't just put the total score. We can't. Interestingly enough, they designed it where we can't derive any severity from just having the total score. We need the individual scores for each category in order to assign this patient to a moderately ill or severely ill level. And this can be done en route to the hospital by ED. We can report that at the arrival of the ED. Post-admission, I think 24 hours by a neurologist. So, and because there's, 4 different categories here, you could potentially end up with 15 or 20 codes on a chart just capturing all the Glasgow Coma scales. But that's important because, again, it's huge for your risk adjustment to report these. So if you already have it in your in your policy to start getting these, then that's probably a change that needs to be talked about sooner than later. Maybe put a form in there. It's something you may have to go through medical records. It's something that needs to be done. It needs to be readily available for the coder CDI at the time of billing and reporting. It needs to be an easy place to find, not buried somewhere on a flow sheet in a pile of 10,000 other nursing notes. While on that topic, that's a problem we run into a lot with looking at dietary consults, BMIs, bin hours, whether or not they what went on during a code. We bury those things in a stack of flow sheets, and the coders and the CDIs can't find them, and they never get reported. Those are all issues that probably need to be looked at in terms of making sure we're hitting all of our quality metrics. So let's look at a couple sample operative notes. We've got missing documentation here. There was a neurostimulator put in, and we got everything that we need. We know it's a St. Jude, we know it's a mini pulse generator, but what we were missing was whether or not it was a multi-ray rechargeable. So little things will be stuff that will have to come up in your tip sheets, in your facilities education as we continue forward. Probably need some templates or tip sheets so that we know that we hit all of these pieces that we need for coding. This is one example. I've got another one here. The was repaired with a muscle patch, but was not documented that it was an autologous or not. Document states that there was no complications, but there were lacerations, which, if it's significant enough to require all this repair, probably should be reported. So, again, it was kind of, the lead was buried here, and that kind of thing will get us into a little bit of trouble because it doesn't explain their length of stay, their readmissions, their continued morbidity, mortality. It did ding us a little bit up front, but it ends up coming back to haunt us on the back end. So let's see for questions. I think we have about 5 minutes, so I'll turn it back over to Nathan, and I think he'll unmute the phone. We'll have some discussion if anybody wants to.
Definitely, and thank you, Ellen. Appreciate it. So everyone is now unmuted. If there's any questions, comments, or feedback, please let us know now.